Okay, so now we're starting to talk about obsessive compulsive disorders. And again, I just want to point out in your textbook, the tables are definitely worth looking at because it really just kind of gives you some very succinct information, just kind of in a very short, colorful way so that you can kind of remember some things. There's a nice table about like common medical causes of anxiety, common obsessions and compulsions, and things like that. So do look at your tables when you're doing your reading. Okay, anyways, so obsessive compulsive disorders, there are several, but the main component of these types of disorders is that, especially traditional OCD, the obsessions are the thoughts, impulses, or images. They could be like a mental image that persist and recur so that they cannot be dismissed from the mind. So they're intrusive. They intrude into the person's thought process, and a thought comes to their mind. They can't get it. They can't dismiss it. They can't get it out of their head. So whatever that thought or impulse or image is, they just can't easily let go of it. And then the compulsion is the ritualistic behavior that the person feels driven to perform in an attempt to reduce their anxiety. So it's a very key concept to think about, that the compulsions, the behaviors that people have when they have OCD, the behaviors are very distressful to the person. They don't enjoy them. However, they do reduce their anxiety. So if you think of maybe a person with OCD who straightens up, makes things neat, is constantly cleaning things, it's not that they really enjoy those activities, and it's not like they can stand back and say, look at what a beautiful job I did cleaning and sanitizing my bathroom. They're always going to find something else that, they're going to find a speck or a piece of dust somewhere, a speck of dirt, and that's going to distress them. So really, it's, their compulsions still aren't ever enough to really completely get rid of those thoughts, but it does help to reduce their anxiety. And they just remember that they don't enjoy the behaviors that they're doing that are compulsive behaviors. Whether it's checking, straightening, touching a doorknob, using a Kleenex in order to open a door, something like that, excessive amounts of straightening, measuring things to make sure they're perfect. They don't enjoy those behaviors at all. They're actually very distressing to them and can greatly impact their life. But it does make them feel better, at least temporarily. So we have obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, hair pulling and skin picking disorders, and there are other types of compulsive disorders. So body dysmorphic disorder is when a person kind of obsesses about, they have thoughts about, the intrusive thoughts that they have are pretty much about, they feel that they are perhaps that they're ugly, or that a certain body part, they usually kind of focus in on a particular part of their body, which they feel is very abnormal and distressing to them. I guess the best example I can think of body dysmorphic disorder, and literally I'm just taking a guess because I don't know if this famous person ever was actually diagnosed with this, but I would guess that Michael Jackson probably had body dysmorphic disorder. He really seemed to be focusing in on his face and his nose, and has had multiple surgeries to change his appearance. If you just were to Google Michael Jackson and look at like a timeline of the pictures of him from the time he was a small child and was first beginning to be famous all the way to what he looked like before he died, tremendous difference in his physical appearance. So not only his facial features, but also his skin color too. I think he did, I believe, have a skin condition that I think was distressing to him. And that was another focus of his probable, again, I really shouldn't be diagnosing somebody, but what I'm saying is that that type of just excessive worry and concern with a particular body part, and actually having surgery and seeking treatment for things that really aren't aren't realistic. In my mind, I look at pictures of Michael Jackson when he was a child and a teenager, and to me, he looks perfectly acceptable. But his perception was that he was not happy with the way he looked. Took care of a young woman years ago with body dysmorphic disorder, and her area of distress was also her face. I don't believe she had surgeries, because if you think about it, to have multiple surgeries that are mainly cosmetic, you have to have a lot of money because insurance is not going to be covering that. So if you don't have money to have multiple surgeries to alter your appearance, you're kind of stuck with how you look. And this woman was very distressed. She would look into a mirror and believe she was ugly. And not only that, but she felt that her face was distorted and it didn't look like other people's faces. And that was just completely untrue. She looked perfectly fine, but this illness made her perception of herself be very abnormal. So it really is an interesting disorder, but does cause a great deal of distress to people. Because if you think about it, if you're not happy with your appearance, if you feel like you're abnormal, something's wrong with you, you're going to feel like people are staring at you, and maybe you're not going to go out of your house, and it's going to greatly impact your social and work relationships. Hoarding disorders is definitely part of obsessive compulsive disorders, and I'm always fascinated when I watch the television shows on hoarders, and just to see how people's homes can become so incredibly cluttered, and that they absolutely can't get rid of anything. They can't throw things away. Old containers from frozen meals and soup cans and newspapers and magazines from 20 years ago. They just can't get rid of anything because they think there's always going to be a use for something in the future. And, and they end up really saving everything, and it becomes a really dangerous situation where people can't even walk from room to room. Sometimes they have a path. And if you think about if people get older and they are living in that type of situation, they maybe can't move very quickly and they can't get out of their house. Say if a fire starts, how are they going to get out of their house quick enough? Or even just to ambulate safely. So it really does become a very dangerous type of situation. Hair pulling and skin picking disorders. So trichotillomania is kind of pulling out hair, and I've seen people with this. They can have big bald patches on their head from this. I've known people to pull out all of their eyelashes, all of their eyebrows, most of the hair on their head. So definitely can be a very serious disorder, and it's going to impact your appearance, which is going to impact your self-esteem. Skin picking disorders, I've actually seen somebody with this too, and the skin picking on her face was so bad that it really altered her appearance, and she ended up wearing Band-Aids like all over her face to kind of cover, and also kind of told a story at first about how it was a bad reaction to a medication she had, and it caused all this blistering and stuff on her skin. Well, actually, none of that was really true. And then she decided to be very open about her disorder and described how it was just a compulsion. And, her family was very distressed about it because they couldn't get her out of the bathroom, and they'd have to hide razor blades and scissors from her because she would be, hacking into her skin so much. So these really are very serious disorders. And if you think also about the, especially the skin picking, how you are going to be risking infection. So there's a medical side to kind of thinking about that too. There's actually quite a few other compulsive disorders. There's compulsive gambling. Some people are like addicted to, compulsions, and let me just say this, compulsions and addictions are very closely related. So some people have like a pornography or a sexual addiction. That is definitely part of OCD. Again, gambling, social media. Some people are addicted to social media and compulsively use social media. Gaming, playing video games. There's so many things that we can possibly be addicted to. And again, addiction and compulsion they're so closely related that sometimes it's kind of hard to separate those. There are also different types of brain injuries, traumatic brain injuries, Huntington's disease, Parkinson's, that also can cause some compulsive type behavior. So it could be due to a medical condition. So just a little audience response question. A patient complains of frustration with his impulse to use tissues to grab anything and everything around me. I just feel clean and safe doing it that way, but sometimes if I don't have a tissue, I can barely stand to open a door. So this patient appears to have which anxiety problem? So obviously that would be obsessive compulsive disorder. So we always apply the nursing process. So we assess, we plan, we make our nursing diagnosis, we identify our outcomes, and we always evaluate. So we are definitely going to be looking at assessing for different types of symptoms. And again, we always want to do, as part of our assessment, do a self-assessment, and just to see if you have any particular attitudes and feelings that might be getting in the way of you acting therapeutically. So sometimes, again, with many different types of mental illnesses, we might think that it's the person's fault and somehow they caused the problem to happen, or that very easily they could just stop doing it. You know, why don't they just stop needing to touch everything with a tissue? Why don't they just stop, counting things or lining things up or compulsively cleaning things? Or checking things, going back and checking and rechecking and double and triple, quadruple checking that something is done or that the stove is off. They can't just stop it. It's just not that easy. It also can be really frustrating sometimes to work with people with different types of obsessive compulsive disorders. Very hard to engage with sometimes, and very hard to change their behavior. So it really does take a long time. Therapy and medications is usually very helpful, but sometimes the nurse might feel frustrated because either his or her interventions just aren't working very quickly. So assessment, a very sound physical and neurological exam, again, because there might be a medical cause. We always want to determine what the source of anxiety is, a primary versus secondary source. So primary would, of course, be them having a diagnosed anxiety disorder, or if they're first being diagnosed, we always want to, as nurses, we certainly can help the physician with this diagnosis, collect data, see if there's a family history of any types of anxiety disorders, because they certainly are very much genetic. And a secondary would be maybe a new medical diagnosis, a side effect of a medication, drug or alcohol abuse, or any of those neurologic, Huntington's, Parkinson's, head injuries, any of those other types of neurological issues that could possibly be causing some of the symptoms. So we as nurses can kind of help the physician to figure out the puzzle. We always want to determine the current level of anxiety, and the most effective way we usually do that as a nurse is to ask the patient to rate their anxiety on a 1 to 10 scale. Now, a 10, somebody says their anxiety is a 10 or an 11. Sometimes people like to overly, use that scale and use numbers that we don't even have there. But if they're able to talk to you and explain things and listen to you, just remember, a 10 on a 1 to 10 anxiety scale, they would be in a complete panic, and they would not be able to talk to you. They would be just completely so absorbed in themselves that they would not be able to even answer your questions or focus on anything outside of their own inner feeling of anxiety. So just kind of keep that in mind. And we do have to take those rating scales a little bit with a grain of salt, because sometimes people just don't use those quite appropriately. Or sometimes if patients are in the hospital, they want their anti-anxiety medication and maybe they're drug seeking. Maybe they truly do need their meds, but maybe they're also drug seeking because they like the way the meds make them feel. And then they may exaggerate that scale a little bit. So I have seen people say their anxiety is at 11 or a 12 or a 20, but truly, if their anxiety was that high, they would be in a panic state and they wouldn't even be able to verbalize it to you. So just kind of keep that in mind. We're always going to assess the potential for self-harm, and that self-harm might be from like skin picking, hair pulling, things like that people do when they have compulsions. This is really an unusual situation, but an example from my own clinical practice was a patient had Tourette's disorder. So that's another neurological disease. He had Tourette's, and the compulsion, what the compulsive behavior that he had was pulling out his own teeth, all of them with a pair of pliers, because he said that the obsession, the thought about needing to pull out his teeth was so strong, it was stronger than the pain that he felt pulling out his own teeth. And he was only in his 20s, in case you're wondering. And yep, he pulled out, he was in his 20s somewhere. I don't remember if it was early 20s or late 20s, doesn't really matter. But he literally took a pliers when he was at home before the hospital, and he pulled out all of his teeth because the pain, the painfulness of having that compulsion, it was, or that obsession, that thought was so strong, it was stronger than the pain he experienced. So I will never forget that example. So that is another, I know that's an unusual example, but people are at risk sometimes for self-harm if they do have that obsessive thought that is so strong that it supersedes everything, in their everything else in their life. So we always want to do a complete psychosocial assessment. Ask the patient about causes that they can identify. If they can identify maybe some triggers to their anxiety, that would be a very helpful thing. And again, always do that self-assessment and make sure that your thoughts and attitudes and feelings are going to be conducive to a therapeutic relationship and helping that person to decrease their level of anxiety. So some nursing diagnoses that we might use. Anxiety. Well, of course, that's an obvious one. So we do have to, that's definitely, it's actually a medical and a nursing diagnosis, but we can use anxiety related to whatever might trigger or stress them out, evidenced by patient rates their anxiety as an 8 out of 10. Patient is tremulous, unable to focus, whatever symptoms of anxiety that they're showing. It might even be a change in their vital signs. Maybe their pulse becomes very rapid and they have trouble breathing. They have shortness of breath when they're anxious, or they get nauseous. So whatever symptoms that they are experiencing or telling you about would be part of that evidenced by. So, all right. We hope that the person is going to self-monitor their intensity, that they can tell us how they rate it, and that they're going to be using reduction techniques. That would be part of the goal. We would want them to use anxiety reduction techniques, and that they would be able to function in whatever role that they're functioning in. Ineffective coping. So we are going to be looking for effective and ineffective coping patterns, and we hope the patient is going to ask for assistance and information to learn new coping. And chronic low self-esteem. So people with these disorders can feel very badly about themselves, and it can become chronic if the condition isn't helped. So they do need to verbalize self-acceptance and increased confidence. So for self-mutilation, that is definitely a diagnosis that fits very well with this type of disorder, and we hope that the patient can identify like predictive feelings, like they understand when they are going to self-harm, and again, skin picking, hair pulling, anything like that could, pulling out their teeth, whatever, so that they can kind of understand when they're going to have those feelings, kind of predict those, and practice self-restraint, and again, substituting more healthier behaviors than doing the self-harm and the mutilation type of behaviors. So planning. Patients don't usually require inpatient admission. However, there are times when, maybe they don't get admitted just for this type of behavior, but maybe they're admitted with a couple of other different problems because perhaps their self-esteem and they have depression that's going along with this anxiety disorder, and they're suicidal. So perhaps at that point they may need hospitalization. There is an inpatient unit. My understanding is at Rogers in Milwaukee that they have an OCD inpatient unit, and that would be for people who have such severe symptoms that they can't get on with their life. And I have seen patients, even when I worked in Rochester, New York, on a neuropsych unit, we had patients that were admitted for OCD, and maybe they had other issues too, like depression again can go along with that. But the OCD was the thing that was so impacting their life that they couldn't do anything. This one young woman I remember was very, very phobic about, so phobias kind of come into play here too, but she was kind of very phobic about germs, and she had OCD types of thoughts about germs, and then rituals. The behaviors, the compulsive behaviors were hand washing, especially not being able to touch things. She hand washed until her hands literally looked like raw beef. They were red, they were horrible, again, opening herself up to infection. And her compulsive behavior took up so much of her day that she was not able to accomplish anything. She was in her 20s. She was not able to develop a relationship with anyone. She couldn't live independently. She still lived with her parents. She didn't go to college. So her entire life was truly on hold because of the severity of her OCD. So I know it says patients don't usually require inpatient admission. However, there are patients that, again, think of that continuum. There are patients that have things that are so severe that perhaps they do need inpatient, and outpatient just wouldn't cut it for them. Maybe when they get better enough from inpatient that they can at least function in their daily life, then perhaps they can graduate to just receiving help outpatient. So again, the planning phase involves selecting community-based interventions. If they are able to, if they're lower on the continuum and maybe the symptoms are just impacting their life, maybe just a little bit, but not to the point where they can't function, a community-based outpatient program would be very helpful. We want to encourage active participation in the planning to increase positive outcomes. So in other words, if the patient is really completely 100% on board with what interventions we're coming up with, then they are more likely to follow through with those rather than us just telling them what to do. If they're part of the planning, they're more likely to follow through. But to keep in mind, the patients that have severe levels may not be able to participate in the planning. So maybe their anxiety is so severe or their OCD is so severe that they just can't, they have absolutely no way to really provide any input. Perhaps until they get better and they're more able to stay focused. So the implementation, so those are our nursing interventions. So we have, our interventions can be a little bit different if somebody has mild to moderate levels of anxiety versus severe to panic. So mild to moderate, we usually just have to remember that sometimes patients might need a little bit of extra time to digest what we've just taught them. We may have to repeat ourselves several times. We may have to do a teach back. We may want them to demonstrate different techniques that we're teaching them to reduce their anxiety. And just to remember, they are going to need some reinforcement, that they probably did not get everything you said the first time you said it. Severe to panic levels of anxiety. So people that have a severe level, they are really not catching what you're saying very much at all. I mean, they are a little bit, but they may need step-by-step directions to do something. So you might have to actually sit with them and do some breathing exercises with them and role model for them ways to decrease their anxiety. So if they're in a severe level, they are really missing quite a bit of what you're saying. And again, they need step-by-step directions. They may need even step-by-step to accomplish their ADLs, like brushing their teeth, washing their face, eating a meal. So just kind of think about how that's going to impact our nursing interventions. And if somebody's in a panic level of anxiety, the best intervention is to, number one, remove them from the stimulation. Remove them from all stimulation. Get them to a quiet area. Stay with them while they're in the panic mode. Reassure them that a panic attack is probably only going to last like 10 minutes or so. But honestly, if you had a panic attack, it would probably be the longest 10 minutes of your life. But still, stay with them, reassure them that it's going to pass, and then try to even, get their eye contact as their anxiety level decreases. Try to get them to focus on you. Again, breathe with them, help them to control their breathing, and help them to get past that that difficult episode. So the nursing interventions are much more structured when you get to severe and panic levels. So counseling, we always try to help people to learn ways to avoid anxiety, ways to manage anxiety, distraction techniques, there's so many different types of coping techniques. Teamwork and safety. If somebody is in a panic or severe level of anxiety, they are at risk for self-harm, they are at risk for harming others, they are at risk for just, maybe impulsively doing something that could be harmful, even though that isn't their intention. So the entire unit needs to be aware if somebody is in those types of severe to panic level of anxiety states. And again, promoting self-care activities, because if somebody's anxious, they're not necessarily going to be bathing and brushing their teeth and kind of eating appropriately even, and just doing those basic self-care activities. So we always have to consider that as part of a very important nursing intervention. So back to that case study, Anita recalls the help she experienced when she was treated in adolescence for panic disorder. I remember my dad anxiously driving me to the emergency room while my mom sat in the back seat and held me, just trying to keep me calm. My dad gripped the wheel like he was afraid we'd go right off the road. So just a point to think about here for a second. Anxiety is contagious. Yes, it actually is. Okay, maybe it's not as contagious as the flu, but think about how if you are around somebody who is highly anxious, how all of a sudden you feel anxious. If you've ever taken care of a patient with anxiety, perhaps you've even had that type of experience yourself. You've caught the patient's anxiety. Or perhaps if you're new at your job or in your role as a student, there are times when you might come across as being very anxious with your patient, and just think about how we're going to increase our patient's anxiety if we are displaying anxiety. So anxiety is contagious, and this is kind of a good example about that. So, okay, back to the case study. When we got to the hospital, I remember a nurse came right out to the car and opened my door. She didn't grab me or anything. She just said, "Hi, Anita. My name is Betsy, and I understand from your mom's phone call that you're having a panic attack. I'm here to help you get through it." Then she held out her hand. I've always felt like Betsy saved me that night. So just having that reassuring, calm approach with somebody, I'm here to help you, stay with them. Those are just some super important things to think about when we're helping people through anxiety. So, oh dear, D is not showing up on this slide, and that's actually the correct answer. Okay, audience response question. Hopefully I can remember what D was, because that is the right answer. So, which was probably the most helpful thing Betsy did for Anita that night? Left her by herself in a quiet, dark space to calm down? No, she'd probably be very frightened. Stayed with her, especially because she was a teenager. B, stayed with her and kept up a steady stream of talk about anything at all to distract and soothe her? I don't think so. That would probably increase her anxiety to have somebody babbling at you, for a long time. C, introduced her to a bright, pleasant game with other patients her age to create a much-needed distraction from worry. No, again, way too much stimulation. So I can't read it on here, but I think the correct answer is something like she stayed with her and kept her in a calm, soothing environment until the panic level passed. I can't read it. Sorry about that. Anyways, D is definitely the correct answer, because you don't want to leave somebody by themselves. They might be very frightened. You don't want to overstimulate them. So that's kind of the main concept to get out of that one. So a little bit of a discussion. Suppose you're a nurse or social worker on duty when a child goes missing, but unlike Anita's child is not immediately found. The police arrive, the parent is questioned, and as the search intensifies, you are asked to remain with and take care of the anxious parent. What would be some appropriate interventions for helping a parent experiencing panic level of anxiety? So from what I've just said previously, I hope you can come up with a few things. Certainly, again, decrease stimulation if as much as possible. Take that person to a nice quiet area. Stay with them. Try to get them to focus. If you talk to them, talk very gently, soft tone of voice. You don't want to do anything to increase their level of anxiety. And they will eventually come out of that panic state, even though they might still continue to be highly anxious about their child missing. But at least to get them out of that panic state and stay with them till that passes. And then you could finally maybe be able to even get some information from them that might be helpful, such as what was the child wearing, how tall are they, what color's their hair. But when they're in a panic, they're not even able to provide any useful information. So implementation. So there are medications that can be very helpful with anxiety. So some of the antidepressants help with anxiety. Other anxiety drugs, benzodiazepines are very helpful. There are other medications that are being used more frequently on 1K, I've noticed, because they have anti-anxiety properties, but they're not addictive. So that's actually another aspect to think about with anxiety disorders, that sometimes people do get addicted to their medications. Because the benzos are very highly addictive. They have street value, so sometimes people sell their meds on the street, or they buy them off the street, or they just simply abuse them. They take them way too frequently. They just increase the dose on their own without going through their doctor. They are very, very highly addictive. So there are other drugs that I'm starting to see used more often. And one of those medications is Benadryl. Occasionally I will see that used. And of course, Benadryl is used most of the time probably for allergic type of reactions, antihistamine properties. Atarax or Vistaril is another medication that I'm seeing used very, very frequently on 1K because, again, it reduces anxiety, but it is not addictive. Another medication that's considered an antidepressant, but actually it's a very poor antidepressant, is called Trazodone. So maybe you've seen that or heard that. But that medication is actually not very much used for depression. It's mostly used for anxiety or sleep because it does have sedative properties. So it's a better sleep agent or anxiety agent. So I've seen Trazodone ordered for HS, for sleep, and I've also seen it ordered in a lower dosage, PRN, for anxiety, because it will sedate the person a bit. It'll help bring their anxiety level down, but it is not an addictive type of medication. So that's why it's kind of important to evaluate who we give benzos to and who we would not want benzos given to. So if somebody has any kind of addictive tendencies at all, we really don't want them on these medications. And I've even noticed a new trend in the hospital, which I'm very pleased to see, is that many times now, if a benzo is ordered, it will say only give if the patient has tried other non-pharmacological interventions to reduce their anxiety. And actually, this just came up in clinical yesterday. So the patient was actually able to use some non-pharmacological techniques. She actually was using aromatherapy. She was using some lavender and reading. And that helped her, and we never had to give her a PRN of her anti-anxiety medication, which was Ativan. So I'm really happy to see that trend, and I do think we need to be working with patients on that, using alternative methods or different medications that aren't addicting, just because of that, that power of the addiction. And most of the time, the physicians are not going to prescribe, even if they prescribe a benzo in the hospital, they're not likely to prescribe that for the patient when they're an outpatient and they leave the hospital. So just something to kind of think about a little bit. So other types of things that we need to work on, we have other types of interventions and therapies, and of course health teaching. Good healthy habits will really help a person with their anxiety too. Exercise is one of the main ones. If somebody is exercising on a regular basis, their anxiety level will be much more easily managed. But I know some patients really balk at that. They don't like to exercise, or they think they have to join an expensive have an expensive YMCA membership, and that really isn't true at all. Just even walking, something like that just raises your pulse up a little bit and gets those endorphins flowing in their brain. That type of thing can be very, very helpful for people with anxiety. along with health teaching would, of course, be a healthy diet. A healthy diet actually helps anxiety levels. People that have complex carbohydrates, if their diet is good with complex carbs, they are more likely to have a better mood and less anxiety, because the complex carbs, not the simple carbs, not the candy, cookies, cupcakes, that type of thing, but we're talking about like more whole grains and oatmeal, the good carbs. Anyways, but when those are digested, they actually turn into serotonin, a serotonin-like substance, and that will definitely help their mood and their depression level. So that's part of healthy diet, exercise, reducing caffeine, getting enough sleep at night. All of just the normal, like, healthy lifestyle type habits can be very helpful for people to reduce their anxiety level. As far as other psychobiological interventions, I'm just kind of looking in the book a little bit on page 290. They're talking about different types of like surgical procedures and deep brain stimulation. Just be aware that perhaps that's something that is a possibility. However, in this area of Wisconsin, perhaps in Milwaukee or a bigger city, those types of interventions might be helpful. And honestly, that would be used if people can't really tolerate medications very much. Integrative therapy and complementary therapies, there are things that can be very helpful, such as aromatherapy. Some people just swear by lavender. Especially lavender seems to have a calming effect. But, there are some different types of herbal and dietary supplements that we have to be very careful about recommending those to patients, because sometimes they're not subject to like FDA approval and vigorous testing and things like that. So it may be out there on social media that this particular herb is the thing to, that's going to help anxiety. But, there are side effects to herbals too. So I think as nurses, be very complementary before you recommend any different types of complementary or, complementary herbal therapies. Your book gives an example of kava, but it sounds like it can, be harmful for the liver. So again, be very careful. I would not necessarily recommend those to patients. So definitely health teaching is a huge thing that we do, and I kind of talked about that already. I'm going to go back to the pharmacological interventions, because your book really does cover lots of other different types of meds that are used. Sometimes if somebody has such severe anxiety, it's just not responding to anything, they may also be on an antipsychotic type of medication. So I think your book just does a really nice job of talking about the different types of meds and therapies that are used. But it's not necessarily a usual medication that we see to treat anxiety, but sometimes people do need an antipsychotic medication. All right, advanced practice interventions. So an advanced practice nurse with a master's degree or higher would be doing therapy with somebody with anxiety. So sometimes it's just helpful for them to work with patients on reducing their anxiety through their thought processes. So maybe sometimes people do something called catastrophizing everything. So in other words, they may say, what if this happens, it's the end of the world. And so they may need some talk therapy to try to help them to understand that there are other alternatives and not to make everything into a catastrophe. So behavior therapy, relaxation training, modeling, so role modeling appropriate behavior, systematic desensitization. So again, in a normal situation, like on an inpatient unit, a staff nurse would not be doing systematic desensitization or flooding or anything like that. Because you really have to be very highly trained professional to be able to do those. So systematic desensitization is actually, I remember the woman I told you about, the young woman with her hands were as raw as like raw hamburger. Her hands were that bad from all her hand washing. I do remember doing this on the inpatient unit, but the psychologist was right there. And so I, as the staff nurse, wasn't leading it, but I was also providing support to the patient, because what he had her do for systematic desensitization with her germ issues, he had her first she would go into the bathroom and they would have her touch the toilet seat with a piece of paper over it. And then they would take the paper away, and then she would touch the toilet seat, and then they would allow her to wash her hands, and then they would have her touch the toilet seat without washing her hands. So it was like gradually getting her to the point where she was no longer terrified of touching a toilet seat. So that's just kind of an example of systematic desensitization. So it's done kind of slowly over time. Flooding is like if you were terrified of snakes or something like that. It would be like putting you in a room, locking you in a room. You can't get out with snakes, full of snakes crawling all over. And of course, what would result from that? Panic, right? Absolute sheer panic. So only a trained professional would do this. And the goal of this type, you might think, oh, that's horrible. That's actually kind of cruel. But what happens is the anxiety level can only go so high. And then it reaches a ceiling. It gets to the highest point that person can experience. And then from there, it can't get any higher. It's going to start to come down. So that person would actually, I personally don't think I'd ever want to go through this, but that person actually then would learn that they don't have to have that same type of extreme response to that thing that's, that they have anxiety about. So response prevention, just teaching people to kind of react before something gets out of control, and so that they don't get all the way into a panic state. Thought stopping is actually something that you could even do in clinical if you have a patient with obsessive compulsive type issues. The form of this I'm familiar with is having them wear a rubber band around their wrist, and every time that compulsive thought comes into obsessive thought comes into their mind, have them snap the rubber band and then count backwards from 10, and then to refocus on something else. So if they learn to do that over time, that can actually be a good way for them to kind of help themselves to overcome some of that OCD type behavior. And of course, cognitive behavior therapy. So you change your thoughts and eventually your behavior will change. So we always want to do an evaluation. It's part of the nursing process. Is the patient experiencing a reduced level of anxiety? Do they recognize symptoms as anxiety related? Because that's actually kind of important that the person realizes when their behaviors are part of anxiety. Does the patient continue to display signs and symptoms such as obsessions, compulsions, phobias, worrying, or other symptoms of anxiety? If still present, are they more or less frequent, more or less intense? So really, are they getting better over time? And it can take a while for people to really get better from anxiety. Usually a combination of meds and therapy is most helpful. So we also want to know if the patient's able to use newly learned behaviors to manage their anxiety. Can they perform self-care activities? So eating, drinking enough fluids, sleeping, hygiene, all those things are very, very important and so basic. Can they maintain satisfying interpersonal relationships? And can they assume their usual roles? Can they work? Can they go to school? Can they function as a family member? Things like that. So we always want to look at those issues. So back to CUSIN, which I kind of said we're going to be thinking about CUSIN throughout all of these learning plans. So quality improvement. So there's actually a scale. No, I'm not going to test you on this, but there's a scale, and then we can develop outcomes and guidelines for care at that. Such as 80% of patients with anxiety disorders are monitored every 6 weeks with this scale, and then after 6 months, 50% are going to be scoring less than 3 on that. So it's kind of a nice way to monitor patients' progress in a very systematic way. So we might think of mental health as being all touchy-feely and just kind of vague and gray area, but and it kind of is, but this is a way to make things a little bit more quantified and actually see that our interventions are, if they are making an improvement in the patient's life. Chapter 16, Trauma, Stress-Related, and Dissociative Disorders. So I think I'm going to start another recording very shortly, and I will start with this chapter.